Chapter 19, the heart. In this lecture, we'll discuss why patients who survive a heart attack should go to the hospital anyway. We'll talk about a couple of devices that might be used at the hospital, including an AED and how these are misused on TV all the time. We'll also talk about the EKG machines and discuss what they tell us about heart function. We'll talk about how the heart sets its own rhythm and how we might develop an ectopic pacemaker, a second pacemaker that can set an alternate rhythm. This is not going to be like growing a third arm or something. We'll talk about calcium and why it's so important for the heart. This will follow on what we discussed last quarter, having this hormone PTH, which makes sure that blood calcium is always at an adequate level, even if this means lowering bone density. And lastly, we'll begin to understand why high blood pressure is so unhealthy for people. To do that, we'll first discuss some basic anatomy. We'll talk about the outer surface and the inner surfaces of the heart. We'll talk about blood flow. We'll move on to the electrical system, and then begin discussing some physiology, including arrhythmias. We'll talk about the conducting system, sounds that the valves make, and then we're going to do a little bit of math. It's not going to involve any numbers, but we want to discuss some equations that can be useful in discussing heart function. For starters, this is a very useful website. I believe you need to have a flash-enabled computer at this time, but it goes through and illustrates what is happening in the heart, as well as showing us the pressures, the EKG waveforms, and the sounds that we would hear if we were to auscultate our patients. So do click or type in this link and go follow this page. Let's start with the circulatory system. Blood is going to return to the heart, and it'll be used. It'll be low on oxygen. The right side of the heart will send this blood to the lungs, where it picks up oxygen and returns to the left side of the heart, which can then pump it to the rest of the body. From the left side, we would call that the systemic circuit. One red blood cell will always alternate between these two. It'll travel to the body, back to the right side of the heart, to the lungs, maybe the left side of the lungs, maybe the right side, back to the left side of the heart for sure, and then back to the body. Maybe up to the head or down to the feet, we're not really sure. But it'll keep alternating between the right and the left sides of the heart, switching from the systemic to the pulmonary circuits each time. Arteries are blood vessels that always carry blood away from the heart. This blood is usually oxygenated, but not always, so we cannot rely on the red and blue that we see in the textbook to identify arteries versus veins. Veins, on the other hand, always carry blood back towards the heart. This is frequently deoxygenated, so most of the veins will be blue in color when we draw them in our book. Capillaries are between the arteries and veins. These are tiny little networks, and this is where gas exchange occurs. Either the dumping of oxygen to the body, or picking up oxygen in the lungs. Now, the red and the blue are convenient color codes for oxygenated versus deoxygenated. In reality, blood is always maroon. When it picks up oxygen, there is a color shift. It becomes redder, a redder shade of maroon. So why does blood appear blue in our veins? Well, that's because this maroonish color of blood, which is a mixture of red and blue, the light waves from that are traveling through the skin, which has some red pigment to it. Orangish yellow in the form of carotene that absorbs some of the red wavelengths, allowing the blue ones to pass through the skin and reach our eyes, and thus our veins appear blue. But just keep in mind that in reality the blood in there is more reddish blue. The heart is situated between the lungs. Everything between the lungs we call the mediastinum, but the heart has its own body cavity, the pericardial cavity, with two serous membranes, a visceral and parietal portion. The heart has a pair of atria in the superior portion. These receive blood from the body or from the lungs. Between the atria and the ventricle are coronary sulcuses. Remember, a sulcus in the brain was a little dip between two bumps, and in the heart it's the same basic pattern. There's also an anterior interventricular sulcus right here, and on the back side of the heart we'd see the posterior interventricular sulcus between the two ventricles. The heart is surrounded by serous membranes. The visceral pericardium actually touches the heart, and the parietal pericardium touches the pericardial cavity. Between these two is fluid that helps lubricate the heart as it moves. In addition to these serous membranes, there's an outer fibrous layer called the pericardial sac. This is tougher and full of collagen fibers and helps to provide a little extra protection for the heart. Because it's collagen, this pericardial sac cannot stretch, and so if any fluid builds up inside of the pericardial cavity for any reason, the pericardial sac cannot stretch, and therefore the heart will not be able to inflate as large as it normally does. The pericardial sac has surgical applications. It can be removed from patients, or I believe even animals, and stripped of all of its cells, leaving behind just the extracellular matrix, which is mostly collagen and fibronectin proteins. And then these can be used in specific surgeries to help promote regeneration of other parts of the body. For instance, in this dental surgery here, we need to replace the gums here. They have receded over the root of this tooth. So a bunch of the patient's tissue is removed, and then pericardial patches are implanted. And then the patient's own cells can migrate into this patch and begin replacing the tissue that we need. Mesenchymal stem cells from the patient are able to adhere to the collagen and fibronectin in the connective tissue of this pericardial patch that we used, and this helped to speed up regeneration. The visceral pericardium is sometimes referred to as the epicardium, or the outer layer of the heart. As we remember, this is a simple squamous epithelium plus a little connective tissue, so it's not a very big structure. The biggest part of the heart is the myocardium. This is all the cardiac muscle tissue. And then on the inside, we have another simple squamous epithelial lining. This is called the endocardium. And it's the same type of lining that we're going to see in blood vessels. This epithelium is called an endothelium. It's a very important cell type. Cardiac muscle tissue is a striated muscle tissue, meaning the actin and myosin were arranged in sarcomeres. But unlike skeletal muscle cells, the cardiac muscle cells were regular cell sized, and they have these Y branches to them, and they are anchored strongly to one another by structures called intercalated discs. Found in these discs are gap junctions, which electrically link one cardiac muscle cell to the next one, to the next one. And because of this Y shape, an electrical signal originating in this cell is going to spread outwards in a wave. When cardiac muscle cells contract, they force blood in one direction. That blood does not flow straight the way that water might flow down a river. Instead, it spirals the way that air flows through a jet engine. This greatly increases the efficiency of how the heart functions in its propulsion of blood. The two atria receive blood either from the systemic or the pulmonary circuit, and the two ventricles pump blood either to the systemic or the pulmonary circuits. Blood returns to the right side of the heart from the superior and inferior vena cavas from the systemic circuit. This blood is then pumped from the right atrium to the right ventricle, past the right AV valve, or the tricuspid valve. The right ventricle then pumps this deoxygenated blood up the pulmonary trunk to the pulmonary arteries, which travel to the lungs. It picks up oxygen here in the lungs and returns to the left side of the heart via the pulmonary veins. These enter into the left atrium, which will pump the blood past the bicuspid valve into the left ventricle. This will then pump the blood out the aorta to the systemic circuit, where the body can now use the oxygen that has been picked up by the blood in the lungs. We then complete the circuit as the used blood now returns back to the right side of the heart. So the superior and inferior vena cavas are the large veins that return deoxygenated blood to the right side of the heart. There's a third entrance into the right atrium called the coronary sinus, which is a tiny little hole that may or may not be visible on the models in the lab room. In a dissection, you might be able to spot the fossa ovalis, which is a little piece of scar tissue between the right and left atrium. What we are looking at in this picture, however, is the bumpy nature of the walls of the atrium. We call these bumps the pectinate muscles. These form because heart muscle cells like to form tubes, just like our skeletal muscle cells do. However, in order to make something spherical out of a bunch of tubes, we wound up with a bumpy inner surface. The right atrium will then pump this blood to the right ventricle, past the tricuspid valve. This valve has 3 cusps, hence it's named tricuspid, and each of these flaps are attached to chordae tendineae, which are tiny little tendons, which are attached to tiny little muscles in the ventricle called the papillary muscles. These tendons and muscles serve a very important function, and that is to prevent efflux, or an eversion of the valve. Without the tricuspid valve, as blood entered the right ventricle, as that ventricle squeezed, it could force blood in 2 directions, up the pulmonary trunk towards the lungs, or back into the right atrium. It's the backwards flow that would be very inefficient. Instead, we've got the valve to prevent that flow. It acts as a one-way door, and the tendons and papillary muscles help to anchor this valve. It must resist a lot of force of the right ventricle as it squeezes. These muscles and tendons help to prevent eversion of the valve and prevent the backflow of blood, so that as the right ventricle contracts, the blood is forced entirely up the pulmonary trunk towards the lungs. The inner wall of the ventricles is bumpy just like the atria. However, these bumps got a different name. They're called the trabeculae carnae. There's one special papillary muscle called the moderator band, which is sometimes visible on our dissections, but is not visible on most of the models in the classroom. It would be located here in the right ventricle, not on the left side. The beginning of the pulmonary trunk is called the conus arteriosus. This is a cone-shaped area that's still on the heart side of the pulmonary semilunar valve. But once the blood gets past the pulmonary valve, we would say that it has entered the pulmonary trunk, which then divides into a right and left pulmonary artery, which travel to the right and left side of the lungs, respectively. These arteries would get smaller and smaller and smaller as they continued to branch, until they form capillaries throughout the entire lungs, where oxygen can be absorbed into the bloodstream, and then this oxygenated blood would return to the left side of the heart via the pulmonary veins. These join up to form larger and larger and larger veins. The inner chambers of the left and the right ventricle are the same size. They contain the same amount of blood in these spaces, even though the left ventricle appears to be much larger. It has a much thicker muscular wall. That's because the left ventricle must pump blood all the way to the top of the head and to the tips of the toes, whereas the right ventricle simply pumps blood a short distance to the right and left side of the lungs. If the right and left sides of the heart were not pumping the same amount of blood, then fluid would build up either in the pulmonary circuit or in the systemic circuit. In this cartoon here, let's pretend that the left side of the heart is failing and is not pumping blood to the systemic circuit. We start with 6 blood cells evenly distributed between the heart, the systemic, and the pulmonary circuits. But as the right side of the heart is pumping more blood, this blood is building up in the pulmonary circuit. This extra fluid would be called pulmonary edema, and this would prevent the lungs from inflating fully, which means that what little blood was returning to the left side of the heart would not be fully oxygenated. This, on top of the fact that the left side is not pumping the blood adequately to the body, would lead to oxygen deprivation. The left and right ventricles, therefore, are the same size, but they are different shapes. For instance, the right ventricle is more pouch-shaped, whereas the left ventricle is rounder. When these ventricles contract, they do not contract completely. There is still some space inside the ventricles after the heart has contracted. This will be important when we get to the equations at the end of the lecture. There were 4 major valves to the heart. The 2 atrioventricular valves are also called the tricuspid and the bicuspid, or sometimes even the mitral valve. These were the large valves between the atria and the ventricles that had the chordae tendineae and the papillary muscles that helped them to resist the force of the ventricles when they squeezed. The semilunar valves, on the other hand, did not have chordae tendineae or papillary muscles. These need to resist simply the force of gravity after the heart is done contracting. The 4 valves in order are the tricuspid, the pulmonary, the mitral, and the aortic semilunar valves. There's a little mnemonic for remembering these, which is toilet paper my ass. If you don't like that mnemonic, you can make up your own, and of course there are multiple names for this mitral valve. The valves close and open in pairs. The 2 AV valves, the tricuspid and mitral valves, close as a pair, and the semilunars will close as a pair. So, in this state, the AV valves are open, and as we are looking from the atria down into the ventricles, blood could be flowing from the atria to the ventricles. But then when the ventricles contract, the AV valves must close off, and the semilunars open up as a pair, and blood is ejected upwards towards the lungs or the body. So that's some basic anatomy of the heart, both superficial anatomy and internal anatomy, including the valves. Next, let's move on to a little bit of physiology. In addition to the cardiac myocytes, the heart contains a fair amount of connective tissue, anchoring those cells together and anchoring them to other structures such as the valves. Collectively, we call all of this connective tissue the fibrous skeleton of the heart. It includes a bunch of collagen fibers for strength, as well as elastic fibers which help to snap the heart back to its original size after it's done contracting. There is a large amount of this connective tissue separating the atria from the ventricles. This helps to electrically insulate the atria from the ventricles, which will be important when we get to the conducting system. It's important to note that collagen fibers are not very stretchy, the way that elastic fibers are. Therefore, there is a maximum size that the heart can fill up with blood. Similar to the way the connective tissue of the pericardial sac had application in surgeries, the fibrous skeleton of the heart may also have application in surgeries of the future. The idea is to take human hearts from deceased patients, not fresh hearts, but hearts that have been dead for a little while, and stripping them of all of their cells, leaving behind just the connective tissue, or the fibrous skeleton. This skeleton could then act as a scaffold, and with the addition of stem cells from a patient, could instruct those stem cells to become cardiac myocytes and form a newly functioning heart, one that could be transplanted back into the patient from whom the stem cells came from, with a very low risk of rejection. There's a low risk of rejection because the cells came from the actual patient, and the only foreign material is the collagen and fibronectin, which should be very similar to the collagen and the fibronectin of the patient's own heart. Right now, these heart transplants are only being done in animals with some success, but the hope is to move this into human patients and reduce the need for finding a specific tissue donor and transplanting a very fresh heart, which right now is very limiting for patients who need heart transplants. There are some more blood vessels, which you'll have to identify in lab, that exit the heart and bring blood to the heart. Now that may seem confusing because the heart is already full of blood. Why does it pump blood to itself via another circuit, the coronary circuit? Well, keep in mind that the blood on the right side of the heart doesn't have any oxygen. So we're going to at least need to get some of the oxygenated blood to the right side of the heart. Also keep in mind that the endothelial cells are an impermeable barrier, so even the left side of the heart needs to pump the blood out and back to its own muscle tissue. The first branches of the coronary circuit are the left and right coronary arteries. The RCA is fairly easy to see on any of the models, but the LCA is hiding behind the left atrium. So if we were to remove that auricle, you would be able to see the left coronary artery, and it very quickly branches into this anterior interventricular artery and a circumflex artery over here. This blood would flow to the muscle of the heart, which would use it up, and then this blood flows back via a bunch of veins, including a great cardiac vein on the front side of the heart, a number of anterior cardiac veins over here. On the back side of the heart, we could find the posterior cardiac vein, as well as a middle cardiac vein, which is right next to the posterior interventricular artery. I don't know why they gave it a different name. And even a small cardiac vein. And all of these veins drain into this structure here, called the coronary sinus, which, as you remember, empties into the right atrium. Here we see a plastinated model on the left, where blood was injected into the coronary circulatory system, and we see that there's lots of tiny little blood vessels everywhere, supplying the cardiac muscle tissue with plenty of blood. On the right-hand side, we see that in this patient, there's an obstruction of blood flow right here. But luckily, blood doesn't need to travel down this left coronary artery. It could, that's the right coronary artery. It could also go down the left coronary artery back in this direction. So what we are seeing is that the coronary circulatory system has redundancies, and this is important. This blockage here would have prevented blood flowing to a large area, but because of the redundant system, we can still get oxygen to most of the heart despite this blockage in one of these major arteries. Next, let's talk about the electrical conduction system and how the heart sets its own rhythm. The heart is capable of generating heartbeats without any input from the brain. Blood will first flow into the atria. These will contract, sending the blood to the ventricles, and then the ventricles would contract. This is coordinated by a group of specialized cardiac muscle cells that collectively are known as the conducting system. These muscle cells fire action potentials, very similar to the way that neurons do, but technically these are not neurons. They're really long cardiac muscle cells that don't have much actin and myosin and therefore do not contract, but do conduct electrical signals. These electrical signals are distributed to the atria first and the ventricles second, causing the rest of the cardiac muscle cells to contract in an organized fashion. It's important to note that we can draw cartoons of these things. If you dissect into the heart, you'll just see a bunch of cells. It's not like the conducting system looks any different, but it does behave differently. One way that these cells behave differently is that they spontaneously fire action potentials. This is called automaticity. The heart does not need any instructions from the brain in order to set a base rhythm. The lead in the rhythm section is the SA node, found somewhere in the walls of the right atrium. The SA node would send signals throughout the atria, which are then collected in this next node called the atrioventricular node, which is located between the atria and the ventricles. If you remember the fibrous skeleton, I mentioned that there was a bunch of connective tissue that electrically insulated the atria from the ventricles. Therefore, an electrical signal from the atria can only get to the ventricles if it passes through the AV node first. It cannot go across any of the other connective tissue. From the AV node, the electrical signals would travel down a single bundle to the bundle branches, which then bring the electrical signal all the way down to the apex of the heart, which then travel back up through the ventricles via Purkinje fibers. A heartbeat starts at the SA node. The muscle cells here would spontaneously fire action potentials, which could travel through the gap junctions, causing both of the atria to contract simultaneously. The reason that the SA node can fire action potentials spontaneously is ridiculously simple now that we've covered the nervous system. These muscle cells have ion channels that are open all of the time and allow sodium to move down its electrochemical gradient. Therefore, a little bit of sodium is leaking into the SA node all of the time. This will eventually bring the SA node to threshold, which will open up voltage-gated sodium channels, and the SA node fires an action potential. This is in contrast to neurons, which required graded potentials to occur out at the dendrites before that cell could reach threshold. The SA node reaches threshold on its own. We start at resting potential, just like before, but because the SA node is leaky to sodium, we slowly depolarize until we reach threshold and then fire an action potential. Once that action potential is done, we spontaneously depolarize again and continue to fire action potentials at a steady rate. This rate is about 80 to 100 action potentials per minute. That would be your heart rate if your brain was not telling it to speed up or slow down. What we can see is that the parasympathetic system slows down heart rate, whereas the sympathetic nervous system will speed up the heart rate. In the absence of both of these, however, a resting heart rate would be somewhere around 90 beats per minute or so, and that is determined by the leakiness of the SA node. After the SA node fires an action potential, it spreads through the gap junctions, through the atria, causing them to contract simultaneously. The only way for that electrical signal to continue is through the AV node, which connects to the AV bundle and the bundle branches. These parts of the conducting system do not connect to any cardiac myocytes, so that electrical signal simply travels from the atria down to the apex of the heart. Then, these branches continue back upwards, and we call them Purkinje fibers, and these relay the electrical signal to muscle cells once again. So the ventricles begin to contract starting at the apex, and then this wave of contraction spreads upwards. The SA node we called the pacemaker. It sets the base rhythm. The AV node delays that impulse before it travels to the AV bundle and the bundle branches. So we have two questions that need answering. Why does the AV node delay the signal? That's to give a chance for the atria to contract fully, therefore filling up the ventricles with blood before the ventricles contract. If the atria and the ventricles contracted at roughly the same time, the ventricles would be mostly empty at the start of their contraction, and this would be highly inefficient. Why do we have this AV bundle and the bundle branches? That's to get the signal that's starting at the superior portion of the ventricles to travel all the way down to the apex before we start contraction. It's important for that contraction to start at the apex and spread back upwards because the two exits, the aorta and the pulmonary arteries, are there at the top of the heart or the superior portion. Therefore, we start squeezing at the bottom up towards the top, forcing blood out those two exit points. The same way that we should squeeze toothpaste out of a tube, from the bottom towards the exit. Because of the relative simplicity of the SA node and its function, as well as the interconnectedness of all of these cardiac myocytes, it's relatively simple for a heart to develop an ectopic pacemaker. The heart does not need to grow a structure, like growing an extra arm. Damage to any of the muscle tissue, such as after a heart attack, if this does not kill the cells, they may become a little bit leaky to sodium. And if they do, they could spontaneously depolarize. Then wherever this damage occurs could trigger an action potential that would spread through the rest of the heart. Only not like the way on the previous slide, in an organized wave, but in one that bounces around the heart. This would be a second signal that the heart would be receiving in addition to the one from the SA node. And just like having two drummers playing different rhythms, that would lead to a very fast and complicated rhythm, leading to tachycardia or an abnormally fast heartbeat. The opposite of this is a condition called bradycardia, where the heart is not beating quickly enough. Let me simplify these cardiac muscle cells now as squares, and talk about how an arrhythmia could develop. In the upper portion, these squares, if they fire action potentials, the electricity will spread to the next cell through a gap junction, and then to the next cell and to the next cell, and so on. However, the action potentials only travel in one direction, and that's because behind each cell that is firing an action potential, the previous cell is going through a state of inactivation, so it cannot fire a second action potential. And for this reason, action potentials should only spread in one direction through cardiac muscle tissue. Now in the bottom portion, this tries to illustrate that we do not have to activate one cell at a time. The Purkinje fibers, for instance, can connect to lots of muscle cells. So these waves can spread through multiple cells at a time, but always with a leading edge. So now let me illustrate this as if the heart only had, 18 cells? and we're going to trigger an action potential on the left-hand side. So those cells will contract and then inactivate. But this wave of contraction will spread from one end of the heart to the other end and then stop. The next wave of contraction could begin again over on the left-hand side when the SA node reaches threshold again. This is our representation of normal cardiac function. However, if somebody has a heart attack, that could damage some of the cells. And maybe they don't contract very well, but it's also possible that they don't inactivate. And now this unhealthy area of cardiac tissue could be a problem for a different reason. It could lead to an arrhythmia. So let's start our wave of contraction again. It will spread through the heart until it reaches this area of damaged tissue. And now, here's where the problem begins. That damaged area, by not inactivating, could allow some electrical signals to pass backwards. Now, if it's unhealthy tissue, it may not be firing an action potential on its own, but cells can conduct electricity. And it's possible for the cells over here now to activate cells back behind them. And now, if we activate this one healthy cell where it shouldn't be activated, the wave of action potentials can spread in a disorganized fashion, bouncing around the heart. What's more, it's because there's never a wave of inactivation. If there's no solid wall saying, do not go past here, the action potential will continue to bounce around through the rest of the healthy heart tissue. And this is known as an arrhythmia. The heart beats in a spastic fashion and in a non-organized fashion, and does not pump blood effectively. The solution to this is to shock every cell at the same time, and that's what an AED device does. It generates an electrical current that can stop an arrhythmia, and that would be the proper use of those devices. In fact, I think the ones today have computer chips that will not deliver an electric shock unless they detect an arrhythmia happening at the time. If a patient was flatlining, as we typically see on TV shows, giving them a shock to their heart would only kill them faster. AEDs do not start a stopped heart. They stop a heart that is beating in an unorganized fashion known as an arrhythmia. So this would be a good spot to take a break. We just finished up the electrical conduction system and discussed two bits of pathology: how an ectopic pacemaker might develop and how an arrhythmia might start. Both of these could be caused by the damage from a heart attack, which is why a patient who suffers a heart attack and survives still needs to be taken to the hospital for care. Next, we're going to continue discussing the electrical conduction system and how we can indirectly measure it using an EKG. Let's start with some review. The SA node contains cells that are leaky to sodium, and they will spontaneously depolarize and fire action potentials that will spread through the rest of the cells of the atria, causing them to contract. This electrical signal must pass through the bundle of His and the bundle branches to reach the apex of the ventricles before causing the ventricles to contract. This wave of contraction would spread back upwards, helping the ventricles to push blood up and out the aorta and pulmonary arteries. For further review, let's recall what happens to neurons when they fire action potentials. First, we had to polarize the neuron, meaning we pumped a bunch of sodium out and potassium in, setting up electrochemical gradients for both of these ions. The inside of this neuron was relatively negative, and therefore sodium really wants to rush back inwards, and it will do so anytime we open up any sort of sodium channel. An action potential can occur when we open up certain types of sodium channels. Sodium rushes in, and then potassium rushes back out. We could trigger an action potential by causing a large enough graded potential. Graded potentials were mediated by the ligand-gated ion channels. These are ion channels that will open up in response to the presence of a certain chemical, and then allow sodium to move down its electrochemical gradient. When that chemical goes away, these ion channels close. The voltage-gated sodium channels were a bit more complicated. They would open up in response to voltage, or some positive ions entering the cell. And when they opened up, then even more positive ions would enter the cell. But ultimately, this would cause the ball and chain to plug up the pore, which inactivates this ion channel. And it'll only go back to the closed state after the cell has repolarized and even hyperpolarized a little bit. And it's at this point, the closed state, that we could potentially open it up again and fire another action potential. We see these same things in the heart, which is why I'm going back over neurons. We triggered a graded potential out of the dendrites of neurons, which could then fire an action potential along the axon, assuming that the axon hillock was brought to threshold. The voltage-gated sodium channels open up first, then inactivate, then go back to the closed state after that area repolarized, thanks to the potassium channels. The SA node does not require the ligand-gated ion channels to bring it to threshold. That's because it's got ion channels open all of the time. It is leaky to sodium. So as sodium rushes in to the SA nodal cells, they will ultimately be brought to threshold and fire an action potential. Therefore, the SA nodal cells will start at resting potential, minus 70, but slowly depolarize to threshold, and when they reach it, they'll fire an action potential. And immediately after the action potential, they will start depolarizing again to reach threshold again and fire the next action potential, and so on. And because the amount of leakiness does not change, this will set up a constant rhythm. The SA node will be firing a baseline frequency of action potentials. We do not require any neurotransmitters to do this, and no input from the brain either. The brain does provide input in the form of sympathetic and parasympathetic stimulation. These can speed up or slow down the rate of action potentials. And the way that they do it is really simple, considering that we've already learned about how neurons work. Acetylcholine will tend to hyperpolarize the SA nodal cells. So now we start further away from threshold, but we still depolarize at the same rate. That means it's going to take longer to reach threshold, and therefore the rate of action potentials, or the heart rate, is slowed down. Now maybe you might be able to guess how the sympathetic nervous system works. Norepinephrine will depolarize the SA nodal cells. It doesn't bring it to threshold, it just brings it closer to threshold. And because the SA node is still spontaneously depolarizing at the same rate, it'll now reach threshold more rapidly and fire higher frequency of action potentials, and our heart rate is accelerated. When the SA node fires action potentials, the electrical signals will spread to nearby cardiac myocytes, and then spread to the next ones and the next ones, because they are all interconnected by the gap junctions found in the intercalated discs. Therefore, the wave of contraction spreads outwards from the SA node, causing the atria to contract. We can't measure that electrical activity directly, the way that we looked at action potentials directly in Chapter 12, but we can do so indirectly, using a device known as an EKG. Or you might use an ECG. The only difference between the two is how you spell cardio. Do you spell it with a K like the Germans, or with a C like the English? These devices place electrodes on the skin to measure action potentials generated by contracting muscles. If your patient is moving around, you'll be getting a lot of electrical activity from their skeletal muscle. But if they remain still, the electrical activity should be mostly from the cardiac tissue. Now, keep in mind that these readings are indirect. We're not measuring the cardiac muscle cells directly, but the electrical signals that they generate from a distance away. And then we compare that electrical activity to the electrical activity we're measuring someplace else, like the arm or the leg. So the signals that we're going to see next on the EKG do not look exactly like the action potentials that we looked at in Chapter 12. When things go up or down, it's not always depolarizing or repolarizing. Nevertheless, we get a pattern that is very consistent between healthy patients. And we can compare the patterns of unhealthy patients to determine what the cause of their sickness is. So on an EKG, we get these three basic waveforms very consistently. We get a P wave first, then this QRS complex, and then a T wave. The P wave represents the atria contracting, whereas the big QRS is the ventricles contracting, and the T wave is the ventricles repolarizing. Before I move on, let's point out a couple of oddities here. It may seem strange that the signal deflects upwards when the ventricles depolarize, and then upwards again when the ventricles repolarize. And just keep in mind that we're not measuring electrical signals the way that we were in Chapter 12, one cell at a time. This is all relative between one part of the body and the next. The other thing that you might notice is that we've got an atrial depolarization, and then two ventricular things, a depolarization and a repolarization. So where did the atrial repolarization go? And the answer to that is it got buried in this much larger QRS complex. So we don't see what's happening to the atria when they're repolarizing, because they get blasted out by the much larger signal of the ventricles. On the EKG, we can find time intervals. Measure the amount of time it takes to go from the P to the QRS, and from the QRS to the T wave. And these intervals of time are very relevant to us. The PR interval here represents the time that it takes the atria to depolarize until the ventricles begin to depolarize. And this is, of course, under the control of the AV node. This sets how much of a delay we have between the atria contracting and the ventricles contracting. We can't look at the AV node directly. It just looks like the rest of the heart. So taking a CT scan would not tell us anything about the AV node. But the EKG does. If this time value changes, it would let us know that there's been some sort of damage to the AV node. The QT interval is the time between the QRS and the T wave. And this represents the time it takes between when the ventricles contract until they relax. So this would tell us a little bit about the health of the ventricular cardiomyocytes. Once again, that's not something we could look at directly. You can't stick a microscope into your patients very easily. But the EKG is a very non-invasive test that tells us a little bit about how the ventricles are functioning. And any changes in these times, if it takes too long for this to happen, if this waveform looks a little bit weird, we might be able to diagnose the patient with a specific problem in their heart without actually looking at their heart. So up in the upper left is a normal tracing, or a healthy tracing. We should see consistent P, QRS, and T waveforms. So that would be one heartbeat, and then they should happen again in the next heartbeat. If you need to do heart surgery, you're going to need to stop a patient's heart, and that's called heart block. And you might notice here that in heart block, the P wave is still happening. So that means that even though you've stopped the heart, the atria are still contracting, but the ventricles aren't doing their thing. There's no QRS or T in these areas here, because we've used drugs to stop the ventricles from contracting. And now it's much easier to perform a surgery on this heart now that it's not moving very much. Down here, we could look at this. You're not going to need to be able to come to a diagnosis, but I do want to point out that the upwards and downwards deflections don't always mean contraction or relaxation. Here is what it looks like when a ventricle contracts too soon. They started to contract before the atria were finished, and now our waveform just looks different. Just looking at this, it would not be obvious to anybody that, oh, hey, that's obviously ventricles contracting too soon. Not based off of the shape of this diagram. But we've seen this enough that when we come across this pattern on the EKG, we know what's happening to the heart at that time. A fibrillating heart has no particular rhythm at all. All of the cells are depolarizing in a more or less random fashion. And the EKG waveform looks like noise. And this would be the worst of all of these, a heart that is not able to pump blood anywhere. Just a few examples of some disorders that you might diagnose on the EKG. One is called long QT syndrome, and this can lead to heart palpitations or fibrillations. And we would treat patients with this condition with one type of drug. Whereas patients with a long PR interval, this is a problem of the AV node, and we have a risk for a different type of fibrillation, and we would treat these patients with different types of drugs. Once again, the purpose of this class is not pharmacology or pathology. I am simply bringing this up to illustrate that the previous slides really do have clinical significance, and therefore you really do need to learn all of the different waveforms of the EKG and what they represent. Next, we need to continue with the physiology of the electrical systems of the heart. Let me review really quickly that we had contractile cells. Those were the regular muscle cells of the heart. And then we had the conductive cells, which included the SA and the AV nodes, as well as the AV bundle, the bundle branches, and the Purkinje fibers. These are the ones that distributed electrical signals to broad regions of the heart and ensured that the atria contracted before the ventricles contracted. The contraction of cardiac muscle cells is a little bit different from the action potentials found in neurons. And that's because cardiac muscle cells contain not only voltage-gated sodium channels, but also voltage-gated calcium channels. The calcium also rushes into the cell just like sodium, depolarizing it. But the calcium channels behave a little bit differently. First, because calcium is important to the action potentials of cardiac muscle cells, having adequate calcium outside of these cells is essential. And that calcium comes from the bloodstream. Therefore, the bloodstream must have a constant supply of calcium. Remember from BI 231 that we didn't want to have too much calcium. In that instance, the body would produce calcitonin to lower calcium levels. But if calcium levels in the blood dropped too low, the body produced parathyroid hormone to make sure that there was adequate calcium. We needed that calcium at the axon terminals of neurons to trigger exocytosis of neurotransmitters, and we also need it to allow cardiac muscle cells to contract. The voltage-gated calcium channels in the cardiac muscle cells remain open for longer than the voltage-gated sodium channels. And for that reason, the absolute refractory period of a cardiac myocyte action potential is longer than the absolute refractory period of a neuron. And this has some significance. The main significance is that an action potential in a cardiac myocyte lasts for a significant fraction of a second, about a quarter or a third of a second. Remember, neurons could fire action potentials up to 200 times per second, but a cardiac muscle cell can only fire about 4 action potentials per second. So what sort of a heart rate would you have if you were firing 4 action potentials per second? Well, 4 action potentials per second times 60 seconds would be a maximum heart rate of somewhere around 200 to 300 beats per minute. And that is the upper limit of what the heart is capable of doing. But as we're going to see towards the end of the lecture, we would never want the heart beating that quickly. That actually diminishes the function of the heart. Going even higher than that would be even worse, and therefore we'd have this maximum setting already in place, thanks to the voltage-gated calcium channels remaining open for a longer period of time than our sodium channels. The cardiac muscle cells only undergo aerobic respiration. In fact, the only time that they would be undergoing anaerobic respiration is during a heart attack, if they're being deprived of oxygen. And that causes a lot more pain than it would in our skeletal muscles. The cardiac muscle tissue does not respond well to lactic acid building up. As a result, healthy heart tissue should only be undergoing aerobic respiration. And in fact, the heart prefers burning fatty acids in the mitochondria to generate the ATP that they need to cause contractions all day and all night long. As the heart beats, the valves have to close. So next we're going to consider another non-invasive technique of identifying proper heart function. And we do that with a stethoscope. And we can listen to the sounds that the valves make when the heart is beating. When the ventricles contract, the two big AV valves must close. And as they do so, the ventricles push blood and it bounces off of these closed valves, producing a percussive sound that we can listen to with a stethoscope. That should produce the first and louder sound of a heartbeat, which some books call the lubb sound. After the ventricles have contracted, the semilunar valves must close next to prevent backflow from those two big arteries. And as that happens, a little bit of blood bounces off of them, producing the second, softer sound of the heartbeat, known as the dupp. There are other sounds that you can listen to with a stethoscope, but I'm not going to be covering those in this lecture. So let's review this one more time, but with a picture. When the ventricles contract, it's the AV valves, the tricuspid and mitral valve, that close up. And when they do, blood bounces off of those valves, and it echoes in these big chambers, creating the lubb sound. When the ventricles relax, now blood bounces off the semilunar valves, creating a quieter sound, but still one that we can easily listen to with a stethoscope, and this is the second sound, or the dupp sound. This occurs, again, when the ventricles are relaxing. You might have noticed on the previous slide it said systole and diastole, and I said contract and relax, but these are our new words now for contracting and relaxing. When the ventricles contract, we call that systole, and when the ventricles relax, we call that diastole. Now I've oversimplified. We could distinguish between ventricular systole versus atrial systole, but in general, if we're just talking about the heart as a whole, we really only care about what those much larger ventricles are doing. So if I don't mention which systole and which diastole I'm discussing what's happening in the ventricles. So the cardiac cycle begins as the atria pump blood down to the ventricles. So the ventricles must be relaxed, and therefore we say the heart is in diastole. This is a good spot to start when discussing the cardiac cycle. Because it's a cycle, we could start anywhere, but this is the typical place to begin discussing what happens. So at this stage, when the ventricles are relaxed, when we're in diastole, the AV valves are open, but the semilunar valves here are closed, and the ventricles will fill up with blood. As the ventricles fill, we will then reach the systolic phase, and the ventricles will begin to contract. Remember, it was the AV node that set the time between when we were in diastole until we reach ventricular systole. So at this point, the ventricles would begin to contract, and those AV valves will close. And as blood bounces off of them, we would get the first sound as we are listening with our stethoscope, or the lubb. Ventricular contraction can be further subdivided into two parts, an isovolumetric phase and a ventricular ejection phase. Isovolumetric means the ventricles are squeezing, but nothing is changing in size, and that's because the semilunar valves haven't opened yet. Ventricular ejection happens when those valves finally open. You could do the same thing with your mouth. Close your mouth, but try to force air out. As you are squeezing muscles, but no air is leaving, you are in the isovolumetric contraction phase. You are contracting your cheeks, but the volume of air inside your oral cavity remains the same. But when you finally generate enough force to start getting some air past your lips, then you are in the ventricular ejection phase. And that's when the valves open up and you actually start forcing molecules out of that chamber. After the ventricles go through systole, they would then return to the relaxed state, or back to diastole. And when this happens, the semilunar valves have to close to prevent any backflow due to gravity, and we get the second sound of our heartbeat, the dupp. It's at this time we're going to get a funny little blip known as the dicrotic notch, which I can't describe right now without a different picture, so I'll come back to this. And here's the picture. This is the picture from the textbook that I just illustrated there with the animated heart. And what we can see are the sounds that we would hear under the stethoscope, and we can look at the pressures that are occurring in the heart. And most of this should be fairly straightforward. When the ventricles are relaxed, the pressure is low. When the ventricles contract, the pressure goes up high. And as they relax again, the pressure goes down low. The only place where things were weird was in the aorta, where we get this extra blip here known as the dicrotic notch. What this means is that pressure starts off low in the aorta. When the ventricles contract and fill the aorta full of blood, the pressure goes up. And as the ventricles relax, the pressure starts to go back down until the semilunar valves close. And at that point, you get this little upward blip, and then the pressure returns back to baseline. So this notch that occurs right here represents the time where the semilunar valves are closing, which creates a temporary increase in pressure in the aorta. But these last two steps I already covered in the animated slides. I just wanted to spell them out for you here on your printout. And then here's the last of them. So that wraps up the electrical system of the heart. We covered the waveforms that we can see on the EKG. The P wave, which is the atria contracting. The QRS, which is the big wave representing the ventricles contracting. And the T wave, which represents the ventricles relaxing. And then we also talked about the sounds the valves make as the heart goes through the contraction cycle, the lubb and dupp sounds. The lubb sound corresponds to the QRS complex. We hear this sound when the ventricles are contracting. And the dupp sound occurs during the T wave. We hear the second sound when the ventricles relax and the semilunar valves have to close. But next we're going to take that physiology that we've learned and use some mathematical equations to help us to understand it further. I'm not going to be using any numbers in these equations. We're going to use them to understand when things go up and when things go down. And ultimately, we want to understand why exercise is good for the heart and why high blood pressure is bad for the heart. But to get to those really important questions, we need to go through a little bit of cardiodynamics and throw some equations at the problem. Here are the three equations that we will ultimately get. I'm going to cover two of them in this lecture. We'll be talking about stroke volume, and we'll be talking about cardiac output. And then in the next lecture, we'll get to this very important last equation, the one that incorporates blood pressure. So this is where we're going. So the first equation I'm going to cover deals with stroke volume, which is the amount of blood that the heart pumps with every heartbeat. And that's going to be equal to the difference between these two things. So what are these things? Let's start with EDV. That's the end diastolic volume. The end of diastole, or the relaxation of the heart, this is when the heart is filling up with blood, and at the very end of that filling phase, it's going to represent the maximum amount of blood that the heart starts with. And then we squeeze, and that's systole. And at the end of systole, you've squeezed all of the blood that you're going to squeeze out of the heart. Now it's not all the blood, it's just all that you're going to eject. There's still a little blood left over. And the difference between these two, what you started with and what is left over, is the amount that you pumped out with a single heartbeat. That is what this equation represents. The stroke volume, or the amount of blood we pump out with a single heartbeat, is equal to what you started with minus what is left over. Let's begin by focusing on what we start with in a little more detail. This is going to be influenced by venous return, or how fast blood is flowing into the heart, as well as how much time you have to fill. And this is the time in between heartbeats. At rest, blood is going to be flowing relatively slowly, so EDV should be fairly low. But with exercise, as the heart pumps faster and harder, the venous flow will be higher, will be filling up faster. Therefore, with exercise, EDV tends to increase. We are going to be starting with more blood in the heart, and this is going to help us to pump more blood, which is exactly what we want to do with exercise. I start with a higher number, therefore the amount that I pump should be a higher number. But we also have to worry about filling time. At rest, the heart rate is slow, therefore you've got a lot of time to fill up the heart. With exercise, though, the heart rate is faster, so we actually have a shorter amount of time. Now, up to a certain point, this isn't going to matter. But with pronounced tachycardia, if you have a really high heart rate, this can actually mean that our filling time is so short that the ventricles don't fill up with nearly as much blood. So this is one reason why we don't like tachycardia. There becomes a point where the heart is beating so quickly that it starts pumping blood inefficiently. We don't have enough time for the ventricles to fill before they're ejected. But that's an abnormal situation. When we are exercising under regular situations, a faster heart rate is not going to be so fast that it decreases the fill time to a point that we notice. So, under healthy conditions, as we exercise, the increased flow rate that we saw on the previous slide definitely leads to an elevation in EDV. I'm starting with a larger amount of blood in the heart. Next, let's talk about the factors that affect how much blood is going to be left over when I'm done contracting. And those factors are going to be called preload, contractility, and afterload. And again, we are focusing on how much blood is left over in the heart when it's done contracting. Preload is the amount of force being placed on the ventricle walls at the beginning of contraction. And it turns out if we fill up with more blood, this generates more preload, and that will cause the blood to eject faster when those semilunar valves open up. As a metaphor, if you were to fill up a balloon with a little bit of air and then release it, the air would escape from that balloon, but not very fast. But if you fill that balloon up with a lot of air, and it's under more force, and then you let go, the air will escape from that balloon much more quickly. And the same thing happens to blood in the ventricles. If there's more force on the inside of the ventricles, when you open up the exit, that blood will eject faster, and therefore you will be ejecting more blood. There will be less left over in the ventricles when you're done. So a higher preload should lower ESV. Next up is contractility, and this one's really simple. If you squeeze harder, you will force more blood out. Therefore, ESV should be lower. And that's exactly what the sympathetic nervous system does. It not only speeds up heart rate, as we previously discussed, it causes the cardiac contraction to be stronger. And when it's stronger, we force more blood out. Therefore, we've got less left over. So, sympathetic stimulation also lowers ESV. Some other hormones can do this as well, but we're going to be focused on epinephrine and norepinephrine. Lastly is afterload, and this is going to help to explain why high blood pressure is bad for us. Afterload is blood pressure. If I have low blood pressure, it's going to be fairly easy for the heart to pump blood into the aorta and pulmonary arteries. But if I have high blood pressure, due to arteriosclerosis or other reasons, that means there's more force that the heart has to work against to try and get that blood into the arteries. And that might mean more blood is left over. So with increased blood pressure, we're going to see that this tends to increase ESV. And if we're subtracting a larger number, we're going to see that that decreases stroke volume. And ultimately, we're going to understand that that's going to be bad for the heart. For right now, it's just going to make the heart work less efficiently. We're going to have to try and compensate. And it's going to be that compensation that'll be the unhealthy part. So those were the factors that affected stroke volume. If I had a larger beginning or a smaller amount left over, both of those things will increase stroke volume. So a larger EDV could come about because of an increase in the fill rate or a longer filling time. A smaller ESV could come about because I have increased preload. And that's going to be because maybe I've got increased fill rate. I've got increased contractility, and all of these things go together because the sympathetic nervous system will cause all of these things to occur. But I also want a lower afterload. If my blood pressure is too high, that could be going against what I want, which is a smaller ESV. Our next equation is going to take that stroke volume and multiply it by heart rate to get something that we're going to call cardiac output. This is the measure of the amount of blood that I'm pumping every minute. And it's going to be equal to the amount of blood I pump with one heartbeat multiplied by the number of heartbeats per minute. So we now have to discuss what affects heart rate. And we've already talked about that. It's the sympathetic and parasympathetic nervous system. Sympathetic fibers, originating in a region of the medulla oblongata called the cardioacceleratory center, can depolarize the SA node, causing an increase in the rate of contraction of the heart, and this increases heart rate. Whereas parasympathetic fibers, also from the medulla oblongata, but from another region called the cardioinhibitory center, these fibers, which are part of the vagus nerve, can hyperpolarize the SA node, slowing heart rate. And if we increase this number here, that would increase cardiac output. But if we decreased heart rate, that would decrease cardiac output. And of course, as we discussed, these fibers are under the control of the medulla oblongata, which receives inputs from baroreceptors as well as chemoreceptors found in the aorta and carotid bodies. So our sympathetic nerves come from the sympathetic chain, and the postganglionic neurons release norepinephrine onto the SA node, which will cause depolarization. Whereas the vagus nerve contains parasympathetic postganglionic fibers, which release acetylcholine onto the SA node, which binds to the muscarinic acetylcholine receptors, which in turn cause hyperpolarization. So our resting heart rate is going to be determined by the SA node and then the amounts of sympathetic and parasympathetic tone. Typically at rest, parasympathetic tone is going to be predominating, so our resting heart rate will be a bit lower than the base rate set by the SA node. Just to review, the SA node can be depolarized or hyperpolarized by sympathetic or parasympathetic neurons, and that'll change where we start from, but the threshold is always the same. The SA node will depolarize spontaneously to reach threshold. This is the baseline heart rate that the SA node would be setting. With parasympathetic tone, this will hyperpolarize the SA node. We start further away from threshold, but depolarize at the same rate. Therefore, it takes us longer to reach threshold, and the interval between heartbeats will be longer, or we'll have a slower heart rate. Conversely, sympathetic tone depolarizes the SA node, and this accelerates the heart rate because we're now starting closer to threshold. Norepinephrine is the neurotransmitter that depolarizes the SA node, binding to adrenergic receptors. These receptors can be blocked with a class of drugs known as beta blockers, and this tends to diminish sympathetic tone to the heart. We don't completely block norepinephrine, we just reduce the amount of the signal and allow parasympathetic tone to predominate. Therefore, this tends to hyperpolarize the heart. We could do the same thing by dumping acetylcholine onto the heart, but pharmacologically that's actually trickier than blocking the adrenergic receptors. Therefore, we do this sort of double negative. We block the sympathetic in order to increase parasympathetic tone. Next, this will also help us to explain how sympathetic activation increases the strength of muscle contractions. So norepinephrine binds to an adrenergic receptor, one of those G protein coupled receptors, which activates a G protein, which activates adenylate cyclase, which makes cyclic AMP, which can then open up calcium channels, either on the plasma membrane or here on the sarcoplasmic reticulum. Calcium, because it's a positively charged ion, will tend to depolarize this muscle cell, bringing it closer to threshold. So that explains the increased heart rate. But calcium channels, by allowing calcium into the cytoplasm, that calcium will bind to troponin, which gets out of the way, allowing myosin to bind to actin. So with more calcium in the cytoplasm, we're going to get more myosin binding to actin, and that means a stronger contraction. So sympathetic tone not only increases heart rate, it also tends to increase stroke volume by decreasing ESV. The heart squeezes harder, so there's less blood left over, meaning more blood was pumped out. So our sympathetic tone increases cardiac output for two reasons: increased heart rate and an increased stroke volume. Next up is the atrial reflex. This is a different reflex from the baroreflex. And what this does is that when the heart fills up with too much blood, it'll trigger a contraction. And this prevents the heart from overfilling, which could be a problem because cardiac muscle cells and all of the collagen fibers that help to anchor them together don't stretch very well. They can contract and then bounce back to their original shape, but we wouldn't want to stretch them out too much. So to prevent the heart from overfilling, we've got this reflex that will automatically activate a contraction of the ventricles, even if the SA node isn't telling them to do so. So that's the cardiodynamics that we need to go over for now. We talked about the stroke volume equation, and stroke volume was equal to the amount that we started with minus what is left over. And do go back over these 2 + 3 factors that affect EDV and ESV. And then we added one extra layer of complexity by multiplying that stroke volume by heart rate to get our cardiac output. And heart rate was primarily regulated by the sympathetic and parasympathetic systems. The SA node, of course, sets the base rate, but we modify that with norepinephrine or acetylcholine. Before I move on, I just want to show you the textbook image that supposedly simplifies everything for us. Now, this image here actually is useful. It's not useful to me to look at all of this all at one time. This doesn't tell me anything about the heart all at once. But every one of these arrows is something that I covered on one of the previous slides. And therefore, you should understand why each of these arrows are here. Don't try and look at them all at once, but do go through them one at a time. So this is a useful slide to review. Secondly, this will help to illustrate a little bit about how it is so difficult to try and treat patients with high blood pressure. We're not even at the blood pressure part yet. We've just stopped short at cardiac output here. Nevertheless, if I were to increase venous return, that would tend to increase preload, which increases these things, which increases these things, which will ultimately increase cardiac output. That's what would happen if nothing else changed. Of course, we're going to have some negative feedback mechanisms. And if you do this intentionally to your patient, if you could increase this, your patient's body might change some of these other factors to compensate. We've got lots of factors that could be changed in the opposite direction to compensate for what it is that you're actually trying to do in your patient's body. And that's going to make managing blood pressure difficult. Before we get to blood pressure, though, that'll be another chapter. Let's wrap up with a little bit more physiology and disease. Ultimately, we need the heart to keep beating through our entire lives. When it fails, we die. That's called congestive heart failure. So we're going to want to avoid these things. We're going to want to avoid arteriosclerosis and atherosclerosis. Those will be topics of the next chapter. Those can lead to high blood pressure, and we already covered one reason why high blood pressure is bad. That increases afterload, which will tend to decrease stroke volume. We also want to avoid heart attacks. We covered two reasons why we wanted to avoid those today. It increases our risk of having a subsequent arrhythmia and can even generate an ectopic pacemaker, which will lead to tachycardia. This last one here is pretty interesting, dilated cardiomyopathy, or an enlarged heart. It turns out things that might damage the heart. If we started with a healthy heart and it becomes damaged, one way to compensate for that damage is by growing a larger heart. So if a patient has an enlarged heart, that could be a sign that they've suffered some sort of heart damage previously, and that's not healthy. On the other hand, athletes will often have cardiomyopathy as well. They'll have really large, healthy hearts. So simply having a large heart is not necessarily a sign of an unhealthy heart. It could also be a sign of a healthy heart. But you could probably tell whether your patient is in really good cardiovascular health, and therefore their enlarged heart is a sign of good health, or whether your patient isn't physically fit, and therefore their enlarged heart is probably a sign that they are unhealthy. So that covers two of the three equations that we'll be concerned with when it comes to cardiodynamics. We said that stroke volume is equal to the EDV, how much blood you started with, minus how much is left over, or ESV. And then if you take that stroke volume and multiply it by heart rate, that'll give you the amount of blood that the heart pumps every minute. You'll notice I didn't use any numbers. Clinically, we don't try and calculate these things. What I want you to be able to do is use these equations to understand whether cardiac output is going up or down when some of these other values change. For instance, if the heart contracts with greater force, that will decrease ESV. That in turn increases stroke volume, and if nothing else changes, then cardiac output would go up. But what we're going to see in the next chapter is that if stroke volume goes up, that could allow you to have a lower resting heart rate while maintaining cardiac output. And that's something that we're going to see. People with stronger hearts tend to have lower resting heart rates while having the same cardiac output. We talked about factors that affected heart rate. That was sympathetic and parasympathetic systems. And we talked about things that affected stroke volume, and then talked about a few other changes to the heart. But that's going to wrap up Chapter 19. Be prepared to continue with these equations in Chapter 20.